Welcome, everybody. Thank you so much for taking the time to join us for our webinar today, an in-depth look at expanding school Medicaid programs. We're excited you all could join us and hope that you enjoy today's webinar. My name is Alex Mays, and I'm with Healthy Schools Campaign, which is the organization that's hosting today's webinar. For the last 4 years, Healthy Schools Campaign has run the Healthy Students Promising Futures Learning Collaborative, which supports 15 state teams in expanding access to Medicaid-funded school health services. A lot of information that we're going to be sharing today includes lessons learned from the Learning Collaborative, and all of our presenters are active participants in the Learning Collaborative. We're also excited to be joined today by a number of our Learning Collaborative members and invite anyone who's interested to learn more about the Learning Collaborative and Healthy Schools Campaign's work to support expansion of school Medicaid programs on our website. Our webinar today is going to run for about an hour, and we will be recording the session, and we'll certainly share the slides as well by the end of the week. So look out for an email from GoToWebinar with links to both of those. We're also going to save 15 minutes at the end of the webinar for a question and answer session with our speakers. So feel free throughout the webinar, as your questions come up, send them in through the questions box, which is located on the control panel. And clicking that send button will collect those questions, and we'll be sure to get to them at the end of the webinar. Next slide, please. So for today's session, we're excited to be digging in more around school Medicaid, and specifically the expansion of school Medicaid programs. For more than 30 years, Medicaid has played a key role in paying for school health services. And today, new opportunities exist to enhance the role that Medicaid plays in school, creating a sustainable source of revenue to support school-based health and behavioral health services. Since the 2014 reversal of the free care policy, 13 states have expanded their school Medicaid programs and have or are projected to increase their federal revenue. And we really see this increase in federal revenue for critical health services as being more important than ever as schools look toward reopening and providing care for students who will have significant unmet health needs. So in today's webinar, we're going to give a short overview of the movement to expand school-based Medicaid, just to level set, and then we're going to hear a presentation that will give a big picture overview of what's been happening in states all across the country to expand their school health services programs. And then finally, I think that one of the most exciting parts is we'll hear from two speakers who have been really in the middle of this, Colorado and Michigan, who have recently expanded their school Medicaid programs, and they'll be sharing lessons learned from that work. So we really hope that you walk away from today's session with a better understanding of the opportunity that an expanded school-based Medicaid program can mean for your state or school district, and how states are leveraging this opportunity to support the delivery of school health services. Next slide. I just want to take a moment to thank our funders who make hosting today's webinar possible. They're listed here, and we greatly appreciate their support for this work. Next slide. So we have 4 wonderful speakers joining me today. Lena O'Rourke, who's with Healthy Schools Campaign, Melinda Hollinshead, who's with the Public Consulting Group, Shannon Huska with the Colorado Department of Healthcare Policy and Financing, and then Kathleen Mary with Wayne County Regional Education Service Agency in Michigan. I'll introduce each of our speakers before they present, but greatly appreciate them all taking the time to join us today. Next slide. So without further delay, I'll go ahead and introduce our first 2 speakers who are going to set the context for today's webinar and give a big picture overview of what is happening in states across the country. First, we have Lena O'Rourke, who is founder and principal at O'Rourke Health Policy Strategies. She's an experienced healthcare advocate and strategist and focuses on issues that impact vulnerable populations. Her work specializes in legislative and regulatory strategy around health insurance coverage and Medicaid. And for the last 4 years, I've been very pleased to have the chance to work with her, as she's been a member of Healthy Schools Campaign's team supporting the organization's work to expand Medicaid-funded school health services. And then we're also joined by Melinda Hollinshead, who's a senior advisor with Public Consulting Group and serves as a subject matter expert for health policy, Medicaid, and managed care. She holds a PhD in public administration and has more than 25 years of health policy and program experience. And before joining PCG, Melinda spent 12 years directing the administration of the Medicaid school-based claiming program for the Arizona Healthcare Cost Containment System. We're thrilled to have Lena and Melinda joining us today. So at this point, I will hand it over to Lena to kick us off for today's session. Lena, take it away.
Thank you. And next slide, please. Thank you all so much for being here. I'm going to provide just a little bit of context to set the stage for today's presentations, because we're going to be covering some pretty detailed information, and I want to make sure we have a really good level set of the context. Over the past few years, and in particular, really over the last 18 months or so, there has been tremendous movement at both the state and the federal level for expanding school-based Medicaid programs. This is in part because of a growing awareness between various players in this field of the intersection between health and education and what that intersection means for student health and education outcomes. And states have responded by pursuing increased federal Medicaid reimbursement as a sustainable source of revenue to support state Medicaid programs to support student health and education outcomes. And notably, at the federal level, the Centers for Medicare and Medicaid Services, CMS, has actively been working with states to design these programs and to approve changes that allow states to expand their school-based Medicaid program. The Trump administration has approved a number of states' requests, and there have been a lot of themes that are emerging from these requests. And that's what we're going to talk about here today. What is being proposed in terms of changes for state school-based Medicaid programs? What's being approved? Why do these decisions matter so much? And then what happens once states have approvals? And this is important for many reasons, but I want to anchor this in why it's important, why we're having this conversation today, because there's a lot that is happening, but a lot more that needs to happen over the next couple of months. And the coronavirus pandemic and the resulting move to virtual schooling has influenced every decision in every state and local budget across the country. Students and staff are facing unprecedented stressors and trauma and will return to school, whatever school looks like this fall, with significant unmet healthcare needs. And schools at the same time will be faced with huge pressures to contain costs, which could mean cuts to school health providers, among other things. And I don't want to minimize the challenges school systems face in meeting the behavioral and physical health needs of students and staff and the competing budget concerns. But as part of this response, maintaining and expanding school health services to meet the needs will require predictable and sustainable funding where we can find it. And expanding school Medicaid programs remains a key strategy and a key piece of how schools can think about expanding services and maintaining to meet the children's needs. So this webinar is timely because we've already seen tremendous momentum around states moving forward, and the pandemic puts in real sharp focus the need to look more at this. So this webinar is going to look at the lessons learned from state and district offices to expand their school Medicaid programs, but we are not going to talk about Medicaid's COVID response. That's a conversation for a different webinar that we're happy to have, but this is going to really focus on what that roadmap for expanding school health and school Medicaid programs is to be there for students and staff through the pandemic. Next slide, please. So as background, we know that Medicaid does play a critical role in school Medicaid. And for more than 30 years, Medicaid has paid for eligible school health services, including in students' IEPs and IFSPs. And this impacts a lot of kids. 79% of low-income school-aged children receive health coverage through Medicaid and CHIP, which is almost 40% of all school-aged children. And in 2015, the latest data for which Medicaid, the latest year for which data is available, Medicaid paid for nearly $4 billion in school-based healthcare services, which includes both the special ed and EPSTT services. By comparison, schools received about $12 billion in federal IDEA funding in 2015. So while Medicaid spending on school-based health services represents a tiny fraction of overall Medicaid spending, just 1% of total Medicaid spending, that $4 billion is significant funding into the schools. Next slide, please. Historically, Medicaid's coverage in schools only pays for the services that were in the IEPs and the IFSPs for students who are enrolled in Medicaid. But a recent, well, relatively recent, a 2014 policy clarification removed a barrier and clarified that schools can be reimbursed for all eligible services provided to all Medicaid enrolled students, not just those with IEPs. This policy clarification was known as the free care policy reversal, and this is the mechanism through which states are now expanding their school Medicaid programs and leveraging the opportunity at the same time to strengthen and improve their programs. Next slide, please. Using this free care clarification to expand school-based Medicaid services, states are really seizing this opportunity because it's opened a lot of doors. It increases it by expanding school-based Medicaid, states experience increased and sustainable revenue for schools. It has expanded a number of allowable health services and types of providers who can be reimbursed through Medicaid. It increases the number of students served and the services provided. In this way, schools and states have been able to improve access for Medicare enrolled children, to reduce overall healthcare costs and improve academic outcomes. And now, as states are really struggling with how they will provide their school health services in the coming year, they have lots of different choices and paths that they are considering and reflecting different state priorities. And this tool and all of these opportunities really come together in this moment to look at a path forward. So I'm going to turn over to Mindy in just a second. And what she's going to do is pick up on these opportunities and what it looks like across the nation for how states have approached the decisions under the free care policy, where they stand, and what they're doing. Next slide, please. So you'll be able to see what the trends are and what the possible opportunities are to really approach this new school-based Medicaid program. And as I transition over to Mindy, just in case you're wondering where your state stands, we put up this map with more information, and we can put in the resources after this, more information about each of these state programs. But this shows the state of the various states, the states that have expanded school-based Medicaid as of this year. And you can see just the tremendous diversity of regions and types of states who have expanded their school-based Medicaid programs. So Mindy, I'll turn to you now to pick up on the themes across these states and what we're seeing in terms of this really terrific momentum.
Thanks, Lena. If you want to expand or move through to the next slide, there we go. So to sort of pick up on the conversation on the groundwork that Lena just laid, I mean, I think one of the things that we understand about Medicaid as a whole is that there's no one-size-fits-all model, either for Medicaid at the state level or for school-based Medicaid programs. You know, Medicaid is a partnership between the federal government and the state governments, and there are some things that are federally mandated that you'll see in all states, but then there are many things that are considered state options, things that states can choose from in terms of services that are delivered, providers, payment structures for their programs. Some states are more heavily invested in managed care for their Medicaid populations than other states. So we see that spread across all states, and that's true for school-based Medicaid programs as well, for that same reason, because they're modeled against the Medicaid program that's operational in the state that you're talking about. So what that's meant in terms of expanding school-based programs is that those models then have to expand based on the current structure of the Medicaid program, what the state plan looked like for their Medicaid school-based claiming program prior to the reversal of the free care policy in those states that are choosing to expand. Now, one of the, I think the advantages is that CMS and states have enjoyed a really productive partnership over the last couple years as states have moved in this direction towards expansion of their programs. And in the states that we've seen get approved state plan amendments to include services under that free care model, expanding outside of IEP, IFSP services, have had really good, productive conversations with CMS and have really achieved a lot in a short period of time. So in some cases, you've seen states like Kentucky or Florida as a good example, where the change to their state plan was relatively simple. It required going in and just changing or lifting the IEP language restrictions around it, or making some other minor changes. You've seen some states like Nevada, and there are others that have made really significant changes to their state plans in that discussion with CMS, and based on feedback from CMS, Nevada elevated the language for the delivery of their services in schools to just more mirror their statewide program, as opposed to having a sort of distinct school-based program. And then you've had states like Georgia and Michigan that have chosen to focus their expansion primarily either on nursing and/or mental and behavioral health services. Next slide. Colorado, who you're going to hear from today as well, did a much more comprehensive, as Massachusetts has done, expansion of their program. So trends that we've seen in this expansion and through conversations that states have had with CMS, encouraging states to really look at broader-based language in their state plans for the service delivery in schools, what those eligible providers that can deliver services in schools and how to incorporate them in a state plan that allows that to be reimbursed for services being provided in schools, how to make adjustments to random moment time study and cost settlement calculations to be able to address that expanded population, especially in states that have cost settlement methodologies. And then what flexibilities might exist in the face of this public health emergency. And again, I know as Lena said, we don't want to delve too deeply into the COVID response around school-based services, because that can be a lengthy webinar in itself. But it is important to sort of understand the relationship between the momentum that was already existing in states around expansion and their services under free care, and what that means in the current environment under COVID, and especially because we know that the mental health and behavioral health services, and then the demand on those services, is such a significant part of what we're dealing with currently under the COVID situation. Next slide. So what we've got now is, hang on one second, I'm having a little bit of technical difficulty here. So I'm having to switch over to my own slide deck here. So let me know, it looks like I'm on slide 13, I think here. So we've got the covered services piece. CMS has encouraged states to strike their covered services where they have specifically referenced school-based services, and instead include coverage of EPS, DT, and Medicaid eligible services to elevate that state plan model, so that they're looking at all the services that are offered in their overall state plan, and then saying if those providers that are providing them are eligible under Medicaid, it's being provided to eligible students and meeting all of the Medicaid requirements, then it's a covered service, even though it's being delivered in the schools. That's just a place of service. So, I mean, that's important, because those medically necessary services are being delivered in schools that are being delivered by qualified providers. Being reimbursed in that way makes it possible for states to make changes to their service coverage within their overall state plan, and to then have those carry over into services and provider types that are eligible in the schools, and to be able to recognize those kinds of changes in that broad spectrum in their school environment as well. Next slide. So coverage of new provider types. I mean, this has been an interesting one for schools to work through. And part of that is because schools have many providers, and in the case of behavioral health and mental health services specifically, providers that have been recognized as school-based providers in the past, but who in many cases, if you look at a comparability with providers who are operating in the broader community, many times meet the same credentialing and licensing requirements or certification requirements as other community-based mental health providers. that are working in mental health centers, and states have been able to look at that comparability and make determinations about whether they're able to include reimbursement for those providers in their school-based settings. And it's a process, and again, this goes to that uniqueness of each state. It's not just the relationship of Medicaid and the state plan, also each state's individual licensing requirements and certification requirements. It's important that providers be able to meet the same requirements as those providers that are operating in the community. But again, it helps schools be able to potentially draw down reimbursement for providers who are providing those services if you are able to include those new provider types. Next slide. The RMTS response times and other issues around the RMTS, those are things that have to be worked through with states who have cost settlement methodologies, and working with CMS to expand their RMTS and expand their cost settlement programs under the free care expansion. In one of the things that CMS has looked for with states is to move towards shorter notice of their time when they will have a moment in time, and then shorter response times following that, to make sure that they're getting accurate responses to how they were spending that moment in time. But many states have worked with CMS to discuss what the challenges that are faced in the schools around those short notices and short response times. And again, CMS has created a good partnership with some states and worked through understanding what some of the challenges associated with that and what some of the negative impacts could be with that, and has worked with states to develop state plans around that try and meet the needs of the state as well as the needs of CMS around that. And what we've seen in the states that we've worked in is that it hasn't at this point shown any real negative impact to those response times, where CMS has been willing to provide some latitude to states around that. Quickly, as far as the pandemic time period, CMS worked with states to develop language to allow for waivers to the last quarter, the April-June RMTS quarter, to account for the fact that we had this sudden shutdown of schools nationally and the difficulties that was creating. And they worked very quickly with states to create waivers to help states address that challenge. Next slide. So same thing under cost settlements considerations. CMS has worked with states to approve some additional codes to be able to capture that time under free care, to look at different eligibility rates for students with and without IEPs, to assist states in doing the calculation separately to be able to calculate the time spent and the appropriate costs associated with those two different populations. That's been a critical factor with states who've looked at how to account for free care within their cost settlement methodologies. Next slide. So moving forward, what we've seen is that we had some already really significant national momentum for expanding school-based programs prior to COVID and prior to the school closures, but that momentum is only increasing under the current pandemic situation as a result of what we know will be an increased demand on schools to provide access to those mental and behavioral health services for their entire populations, not just for those IEP populations, as well as the need to figure out how to address the significant budget shortfalls that we're seeing. And the importance of supporting that health for students, and how that's going to be more important now than ever before, not just in mental health, but also in the nursing arena, as states try and figure out how to respond to the current circumstances and maintain a healthy environment when we're ready for schools to go back to the physical locations. So I think that sets the stage then for us to move on to talk to Colorado and Michigan as to what some of the experiences that they've had moving forward with these various things that Lena and I have talked about in terms of the opportunities for expansion.
Great. Thank you so much, Lena and Mindy, for giving that fantastic grounding and overview of what has been happening since the free care policy reversal. Next slide, please. So now I will go ahead and introduce our next speaker, Shannon Huska, who is the Financing Unit Manager at the Colorado Department of Healthcare Policy and Financing. Shannon has worked for the state of Colorado in the Financing Division since 2009, and she currently oversees various certified public expenditure payments, including the School Health Services Program. Shannon is currently involved with both national and local organizations discussing the challenges and opportunities found between education and healthcare. We're thrilled to have Shannon joining us today to share more about what has been happening around this work in Colorado. So Shannon, I will now go ahead and hand it over to you.
Thanks, Alex. Next slide, please. Great, so today I'm just going to go over briefly the process Colorado went through to decide to submit a state plan and how we got approval. Talk about the next steps and how we're implementing the changes, and also talk about lessons learned along the way. Next slide, please. So Colorado, after CMS released the state Medicaid director letter in 2014, started looking at what the free care policy reversal may look like for us. Being a cost-based state, we knew it wasn't a clear consensus that we needed to move forward. We had a multi-phase approach of looking at this and doing an analysis. In phase one, we took existing data that we had with our time study and determined how much time was spent with the existing providers doing free care services. Because of applying the Medicaid eligibility ratio, which we'll talk more about later, we actually found that in the current program that it was, if all we did was lift the IEP restriction and then had to adjust the Medicaid eligibility or eligible ratio, we would actually have many districts that would decrease their reimbursement. So we stopped phase one and we went on to phase two. In phase two, we talked with districts and really looked at how many districts had additional providers to really add that were doing these free care services that we knew could be added. And also how well those additional plans of care were being documented outside of IEP. And we found there were very little already qualified providers that could be added, and we found that documentation wasn't necessarily there. So after phase two, we kind of stopped for a bit. Then CMS gave some additional guidance on how to use the Medicaid eligibility ratio, and that we could use one ratio for the direct service, the current IEP services, and then we could use a different ratio for the rest of the student population, which was key in what we found in phase one. So in phase three, we decided we're going to go through and do a pilot time study. We had 8 districts over 6 weeks, and we had 2 time studies. One was existing providers, so basically the program as it is today, and just lifting the IEP restriction. The second group was new providers that we wanted to gather data on to see if they were performing the services that would qualify under free care, and to see if we really wanted to move forward with adding them. In this phase, we found a lot of key information. We did a lot of slicing and dicing of the financials and the data that we received, and we found that by just lifting the IEP restriction, keeping the program otherwise the way it is, we could bring in potentially an additional $8 million statewide. And to put it into perspective, our program as a state is about a $50 to $60 million federal fund program. So an additional $8 million was significant to us. And with the data we were using at that time, we were probably closer to a $44 million program. So, you know, nearly 20% was significant. Then we found if we were able to add the other groups, such as a master's level psychologist, we felt that we could bring in an additional $4 million potentially. This included a few other provider groups and such, but this group was subject obviously to CMS approval and make sure licensure requirements met state requirements and federal requirements and all that. So we didn't have all of that information then, but we went into it with a huge caveat that we will try to get some additional, but the big bulk of wanting to expand was just lifting that IEP restriction. So phase 4 for us is we decided with stakeholder involvement and talking with a bunch of districts and stuff that we did want to move forward with expansion. So we submitted a state plan in November of 2019. We had a few back and forths with CMS, but nothing major, honestly. The biggest one was asked to submit our time study implementation guide, and I think we got that request in the end of December, and we submitted it back in January. But we got approval for both the time study implementation guide and the state plan in February of 2020. So within the first 90-day clock, we received approval. And we have since updated our time study implementation guide in April of 2020 to add the state of emergency exception language that Mindy referenced earlier. But our state plan and implementation guide will go into effect on October 1st, 2020. And I will go through what some of those changes are. Next slide, please. So the major changes that we made when we updated our state plan, like I said earlier, we lifted the IEP restriction, and we now have other plans of care where medical necessity is established and scope, duration, frequency are defined. These have to be Medicaid allowable services by qualified providers, but it no longer restricts us to just IEP and IFSPs. The time study, we added 3 codes. The biggest significant one is adding a 4C. For us, that's coding the services as other plans of care. I know it's a 2 or 3 or whatever in different states, but for us, the 4B is that current IEP, IFSP services, and now we've expanded to the 4C, which is other plans of care where medical necessity has been established. Then the time study notification, as Mindy referenced earlier, this is a negotiation, and we previously had 5 days notification and 5 days response. We did have some back and forth with CMS on this, and we were able to come to a compromise at a 24-hour prior moment notification. So that does mean if a moment is Monday morning, they will get notification on Sunday. But we have 24-hour prior notification and a 2-day response window. So we have been talking about that with our districts from day one, that we knew that this was probably coming, so they can start to prepare and just adjust their timelines a little bit for that. And then we did add some transportation codes that we just simply didn't have in there previously. The big change was the Medicaid enrollment ratio, where we can use the IEP student utilization ratio for the direct services. We can now use the Medicaid enrollment ratio for all those other plans of care. And we did some changes to the cost pools too. We eliminated our targeted case management cost pool, and we made some updates to some job categories. Mainly, it was just cleaning up some categories that weren't really being used. Next slide, please. We did add some new job categories. We were able to add applied behavioral analysts, speech language pathologist assistants, and school psychologists. Now, all of this still comes with the caveat that they have to meet other Medicaid requirements on licensure. The SLPA has been in the overall state plan for a few years now, and so we actually didn't include them in our pilot at all. So we expect that to have a positive impact on the direct service cost pool as well. Applied behavior analysts, we were able to add it. We will see what that really brings to the state. And school psychologist was probably the biggest and still kind of the one of biggest discussion as well. We are adding this, but our licensure requirements as a state still don't fully align with the Department of Education requirements. So currently, there's a few ways that this can be added. There are some options, but the biggest one is we can have a master's level psych, but they do require supervision. Previously, we were a DORA licensed psych with, so DORA is our state regulatory agency. So DORA licensed with doctorate level. And so we'll see. We think we'll get a couple additional. I don't think it will be the bulk of the expansion, but the biggest of the expansion is lifting the IEP restriction. Next slide, please. Then moving on to plans of care. This was another huge area of discussion and talk with all of our stakeholders and LEAs. We are expanding outside of IEP. And so we want to ensure that those new plans of care still meet Medicaid requirements. So those new plans still have to have established medical necessity, have scope, duration, and frequency outlined in them, and the providers need to log those services. This will be one of the greatest areas of training. As I mentioned in the area where we did our phase 2, we found that not everything would meet these requirements as we did the analysis earlier. So we've been working with districts, so they've had now over a year that they've been working to get all these other plans of care up to date and make them allowable to claim under the new program. Next slide, please. Training is, again, huge, and this is really the first area we've been telling people to train in their district. So we, as a state, are training the coordinators, and the coordinators, we're telling them to really prioritize who you train and when you train them. First, they should train all existing participants, those who have been on the time study for a while now. They need to know how the time study is changing, how the questions are changing. Are they working on IEPs that are standalone? Are they working on an IEP that has a healthcare plan? Is it a healthcare plan that's standalone? These will make a difference on how the moments get coded, and we just want the most accurate information. If it's a healthcare plan that's standalone, that's more of a free care service. If they're working with a healthcare plan that's also on an IEP, that's an existing direct medical service. So we just need to make sure they're training those existing participants first so that we can have a successful program and not have a drop in our time study as we implement. Then we can work on rolling out and then training the new providers and expanding the program to include those new providers that are providing those free care services that have not previously been on the time study. Next slide, please. And what we've learned, training and communication are key. We have been training with our coordinators for about a year in anticipation of rolling out and getting approval. We've been communicating with them as well, with engagement with stakeholders, both community partners as well as our district representatives. We had a very large stakeholder meeting that anyone was invited to last June, and that's the meeting where we decided to move forward. And many of us, myself included, until we finish phase 3, we're not ready to implement the free care program. So after seeing the data and going through that, we have determined that we wanted to and got everyone on board. And I would just say, you know, that communication engagement is key. Also being transparent and continued research and openness. I say that because, as I mentioned earlier, we've had some licensure questions that have come up even since we've got approval. And, you know, as a state, we've been working with the districts to see as much as we can allow, and if there are any other ways we can get different providers with different licensures in the program. So we continue to talk and have those conversations as we move forward, because we know there will be continued updates and new information. And that's all I have. So back to you, Alex.
Great. Thank you so much, Shannon, for that wonderful overview of all the work that is taking place in Colorado around this. We really appreciate it. If you have questions for Shannon, please feel free to send them in through the questions box, and we will get to them at the end of the webinar. So next slide, please. I'm now going to go ahead and introduce our next speaker, Kathleen Mary. Kathleen Mary recently retired from Wayne County Regional Education Service Agency, where she was responsible for Medicaid school-based services for 32 school districts in Wayne County. She has returned to her work, which we are very grateful for, to continue to provide support to all 57 intermediate school districts in Michigan. She also sits on the board of the National Alliance for Medicaid and Education, is a member of Michigan's Policy Work Group, and co-chairs the Intermediate School District Superintendents Organization's Medicaid Subcommittee. So we're thrilled to have Kathy joining us today, and I will now go ahead and hand it over to you, Kathy, to share what has been happening in Michigan around this work.
Thank you, Alex. Next slide. What I'm going to be doing today is walking through how our program began, how we expanded it, how we included general ed students, new provider types, some of which Shannon also shared with you. I also want to explain how our legislature dedicated funding to this effort. We'll look at some lessons learned, what's happening now with the current program, and of course, some barriers. Before I do that though, I do want to explain how school-based services Medicaid runs in Michigan. It is under the direction of intermediate school districts. Basically, those are 56 entities that exist to provide services to their local districts. And the boundaries are pretty much established by county lines. And as intermediate school districts, we provide special education services, professional development, and other support services for our districts. So I work for Wayne-Risa, and Wayne-Risa is the largest intermediate school district in the state of Michigan. Next slide. In December, everybody got that Dear State Medicaid Director letter, and so we looked at it. We have this policy work group, and we decided we're just going to continue to look at it for a couple minutes and not jump in right away. But by July of 17, we decided, yep, let's do it. What happened then, in policy work groups, we worked on how were we going to do this. So when December of 2018, in the wee hours of the morning during a lame duck session, our legislature put in something called 31N funding, and I'll talk about that in a minute. And they also said, in this law, Medicaid agency, you have to go after the free care CMS plan. It was submitted by our Medicaid agency, and in August of last year, our SPA was approved. And then in October of last year, we started our Caring for Students. That's the name that we put on this free care program. Next slide. So here is how our SPA turned out. This is how we expanded services, the new categories of providers we were able to now put on the direct staff pool list. And so now, under this new Caring for Students program, we can receive Medicaid reimbursement for services provided to all our kids if, and the rules apply as we've heard before, the student has to be enrolled in Medicaid. The services have to be covered by EPSDT. Licensed providers have to be approved. And so that to me was the biggest thing. By enhancing the list of qualified providers, we were able to add nurse practitioners, PAs, clinical nurse specialists, marriage and family therapists, behavior analysts, school social workers, and school psychologists. Next slide, please. So now for the buy-in. Everybody really needed to know how this program was going to work in their districts. Therefore, what we decided to do was establish focus groups. And here's the different focus groups and what they focused on. We had a group for the staff pool list. We had one for random moment time study. Finance, how were districts going to report their costs? Shannon talked about plan of care. We know what an IEP is, but now with general ed kids, there still had to be a plan of care. Process work group was the one, actually that was the one that I was on. And we focused on communication. And the last focus group was on audit, what was going to happen in an audit. So people that we put into these focus groups were from our Department of Ed, our Medicaid agency, we had consultants, outside consultants, local district staff. We had a broad range of people to bring their thoughts together. So in the process work group, we realized that what we really had to do was convince our local districts to participate in this C4S program. And we had to do this as simply as possible because we had that 31N, and there's differences between the federal Medicaid C4S program and 31N, which was a state school aid allocation. Next slide, please. So these parallel efforts supported school health. First, let me kind of explain this 31N. It was funding that was included in our state school aid act, but it was grant money. So in other words, if a local district wanted to access this money and there was a pot of $30 million, the way they got the grant money is if they hired new staff to provide these services to general ed kids who are on Medicaid. And that's what created the confusion, because the C4S program was our current school-based Medicaid program, but we got to expand and add more people. So rolling this out was an effort. It took some effort, let me tell you that. Next slide, please. We developed this information to give to the intermediate school districts and local superintendents. And it's just a real simple summary about the differences that occurs between these programs and how 31N works. To add to the confusion, 31N had in that section additional pots of money that you could access if you did made additional, included some additional services. We focused though just on the one that put direct services for students and hiring new staff because they had to meet our C4S requirements. Next slide, please. The legislature, their goal was to encourage local districts to jump into this program. And if they did, they would pay the district to hire these new staff. So it was a win-win situation. And I highlighted this one because I spoke about intermediate school districts. Detroit Public Schools Community District is also an entity that can bill on their own, as well as the Michigan School for the Deaf. But the bottom line was, if you want to increase mental health services to general ed kids, this C4S program would allow you to do that. Next slide. So as I told you, I was in that process work group, and we developed 3 documents to help local districts understand the requirements if staff were in fact going to participate in our new expanded program. So this is just one of them. Next slide, please. And here are the other 2 that we developed. Why did we do 3? Well, we wanted to offer options for staff that were responsible for Medicaid within their ISD. We call them implementers here in Michigan, and we have a group of folks that are actually the boots on the ground people. They are the ones that are responsible for making sure that people receive notice about their time studies, that they're logging services, that they're doing, notes, etc. And they kind of watch over and assist with audits and making sure they have quality assurance plans in place. We also wanted documents that superintendents and district administrators could use. They needed to review so that they understood the requirements if in fact they were going to be adding people to the staff pool list that typically had not been included. Next slide, please. So where are we today? The C4S program is still not fully operational. Why? Because the districts still have questions about who should they add to the staff pool list. Shannon talked about training. I cannot tell you how important that is if in fact you're going to put new people on the staff pool list. They need to understand what the qualifications are, what their requirements are, and what it is that they're going to be asked to do. Additionally, vendors, we have various vendors that work with our intermediate school districts to claim, and there's new codes that are required. Well, now they have to expand their claiming software. They have to get ready for this. And then, of course, COVID-19 came, and every one of us were affected by this, as you well know. But I still say it's worth it. It's absolutely worth it to look at how your state can, in fact, expand these services. Next slide. Were there bumps along the way? Oh, there sure were. I listed 3 of them previously, but there's actually more. The new staff. Okay, you've got money, districts, to hire new staff. Okay, well, where do we get them? They're not out there. We know that there's critical shortages in these categories of staff. Then there's current staff, where we moved, for example, school psychologists who had recently been under our MAC program, or we call it administrative outreach. Well, now we're moving them into the direct service staff pool list. What does that mean? Not only do they have to do a time study, but now they have to file claims. So again, it's training. So there are 31 N staff. They have money to add new staff. We've got to train everyone. But again, COVID-19, you know, and we've all mentioned this, now more than ever, you know that kids need mental health services. In districts, they need more revenue. And in Michigan, the revenue, and for Wayne Risa, it varies across the intermediate school districts, but revenue is obviously increased. Shannon shared some of her numbers, and free care helps us to do that. That's why we're in it. So that's the Michigan story. I thank you, and so I guess I'm going to turn it back to Alex.
Great. Thank you so much, Kathy, for sharing the Michigan story. It's fantastic to hear more about the work going on there, and then just how it compares to the work happening in Colorado. So with the remaining time, we're going to go ahead and move to our question and answer session. So please feel free. We've had questions come in throughout the webinar. Feel free to keep sending them in for our speakers. So the first question, Shannon, I'm going to direct to you. We have one of our participants wanting to know if all services in Colorado are cost settled, or if there are any fee-for-service services.
Great question. Yes, all of our program is part of the cost settlement program. Our interim claiming is fee-for-service with a rate of 0. So everything is in the cost settlement realm.
Perfect. Thank you. And a question for Kathy that I'm hoping you can speak to is wanting to know in Michigan specifically what the qualifications are for school psychologists, how the state ended up defining that and handling that piece.
We followed what the Michigan Department of Ed has for their licensing requirements, and that was approved. I don't have that sitting here in front of me, but I can certainly I can certainly get that out. I don't have it sitting here in front of me what the qualifications are, but we have them, and they are now eligible providers in this new expanded program.
Thank you. That would be great. Yes, we can definitely circle back and share out that additional information with folks. So the next question is, I think if both Kathy and Shannon, if you could just speak a little bit to how you got started. I think that is, obviously you shared a lot of fantastic information and kind of wondering if you could just think back to the beginning and share a little bit more about how you got started, and specifically who was at the table in the beginning, who were the different stakeholders and agencies that were involved in this work.
Sure. This is Shannon. I'll speak for Colorado. So when we got started, I feel like we've got started about 3 different times throughout the process when we first started doing our analysis and stuff. But I think the most important really is when we got down to doing our pilot program and deciding to move forward with the state plan. In our pilot program, we took 8 school districts around the state of different makeups and sizes and different parts of the state to do the pilot test to see if we wanted to move forward. When we received the data from that, we had, like I said, a huge stakeholder meeting. There was about 80 participants, and to put it in perspective, normally we have about 16 participants at a stakeholder meeting. But it included many district staff, community partners, billing agents, as well as advocacy organizations for different provider groups, all of that. We included pretty much anyone and everyone who wanted to be at the table to decide to move forward. And then we just kept in communication on what proposed changes we were making with our stakeholders and where we were in the process with CMS to the stakeholders.
In Michigan, I touched on that we have something called a policy work group. We meet quarterly, and the we is our State Department of Education, our state Medicaid agency, and representatives of the intermediate school districts. We bring to the, and our state vendor, which is PCG. We bring to the table any issues or concerns that we have that we're finding out in the field, and we work through those together as a group. I can't tell you how important that relationship is between those 3 entities, and well, actually 4 entities. So as I stated, when we saw when our DHHS, Medicaid agency, got a letter that free care was now open, we sat back and said, you know, we're not so sure that this is going to work that well for us, being a cost-based state. And let's kind of think if this is something we really want to do or not. So we watched, and because we're active participants in the NAME organization, as well as working with PCG, as well as working with the Learning Collaborative, it became apparent that it was really going to be a good deal for us. So that's why we decided to jump in. We had groups of us sitting down and hammering out some things. But I think the most important part is those focus groups, after we made the decision that this was a go, how do we get the information out to our local districts? That was the biggest thing, considering the size of the state of Michigan and having over 500 school districts within our state. They needed to understand this.
That's great. Thank you both for sharing that. That's really helpful. So we have another very specific question. I'm hoping, actually maybe Mindy, Shannon, and Kathy, anybody feel free to weigh in on this one. We have a specific question about personal care assistance services, and wanting to know both, Michigan, Colorado, if you're billing for personal care services, but then if you are, if you can speak a little bit to the credentials licensure requirements for personal care assistant providers.
This is Shannon. In Colorado, we do bill for personal care, and there's not licensure requirements for personal care services.
Same in Michigan.
And I'll just say from a national perspective, this is Mindy, typically that's not, so personal care is not something that there are federal regulations or requirements around the licensure for, and most states don't have some kind of specific licensure. Some states, Arizona, had in their policy documents to require first aid and CPR, and sometimes it's just a requirement for them to be trained in the specific needs of the student that they're providing care services to, but there usually isn't a licensure process the way that there would be for clinicians.
That is incredibly helpful. Thank you. And so just one more question. I think you all have touched on COVID. We've talked about it within, just the framing of this webinar. I'm wondering, particularly Mindy, from where you sit at the national level, but certainly Shannon and Kathy, if you have additional thoughts to add, just if you're still seeing momentum kind of around this work despite COVID, and how that has or has not impacted interest that you're seeing from states in leveraging this opportunity to expand their programs.
Yeah, I mean, I think that the momentum, this is just built on it, and I think I mentioned that, built on the momentum that I think that we already saw in place, and partly because much of the momentum that we saw for the last 18 months to 2.5 years around free care was really centered a lot around a new appreciation or a new understanding of the need to expand access to mental health and behavioral health services for kids, and that sort of the process was to say at the state level, and I think Kathy touched on this a little bit with sort of the momentum in Michigan that came down through the legislature, and some of this was based on the Safe Schools grants and things like that. But there was a lot of movement around the need to expand access to mental health and behavioral health services, and to do that beyond the IEP. Free care was a way that states, that was sort of a vehicle that states were using to try and figure out how to expand that. And some states, as I said, specifically focused on that. Some states use it as a way to expand their entire programs. I think that the COVID piece, it just heightens that even more. I mean, as I said, we know that there's going to be even greater demand being placed on schools to provide access to those services. There's greater strains on budgets. And so as a way to try and figure out how to increase reimbursement back to schools for services that we know they're already going to be providing. I think the challenge is that at both Medicaid agencies and in school districts, so as Lena talked about, this is sort of sitting at the intersection of those two things. There's so many other challenges they're facing related to this period of time in the pandemic. I mean, Medicaid agencies have so many priorities that they're trying to manage, and so is true for schools who are trying to figure out how to reopen. So I think the momentum is there. I think there's an increased feeling of not necessarily knowing how to move forward around that, which is why I think webinars like this and trying to learn from some of these states that have already gone down this path, even though it was before COVID, can be helpful. And I think what I wanted to say too, and I think it was right around the time I sort of had to deal with the technical issues, the map that Lena showed, where it showed the states sort of that have been approved or in process of getting approved for state plans for free care, didn't look like there's so many states on it. But what I would want to say is there's a lot of states on that map that were gray, and not because they're not talking about it, but because they didn't fall into a category that was being shaded in terms of already having gone through the process of submitting state plans. But I could mention several states on there that I know are actively in conversations with their Medicaid agencies and with their departments of education around what would need to happen to expand for free care. There are several of those states that are in that position right now, and I think it's just figuring out how to do that in the current climate of COVID as well.
That's fantastic. Shannon or Kathy, any final thoughts to add on that point?
No, Mindy said it well. Prior to COVID, as Mindy said, we were watching kids with some serious mental health issues. I mean, all you have to do is talk about the school shootings and suicides. I mean, we knew, and that's why this legislature pushed for increasing mental health services to these kids. Truthfully, I don't know what COVID is going to bring back, but we can make a very educated guess that there will be an increased need for mental health services if and how and when schools open their doors.
Great. Thank you so much. And thank you everybody for hanging on for an extra 5 minutes here. We really appreciate it. So with that, we'll go ahead and wrap things up. I just want to once again thank our wonderful panel of presenters for sharing their expertise. Thank you to all the participants for taking the time to join today. Please do not hesitate to reach out with questions if you think of questions for the presenters after the webinar. And we will send out an email later this week with a link to the recording and the slides. So great. Thank you so much, everybody.
Thank you, Alex.
Thanks.
Thank you.